means we collect, profit, report, and development system, and that can influence the policymakers, program action, and research. And when we install the health information system, then what that is needed, who generates, which form and type of format, reporting frequency, data storage system, and what should be channeled for information. This already been discussed in the first session by Dr. Rahul Kanamazar. And Dr. Redon also mentioned that our budget is very low in national non-contributory. So our health system needs to be reformed, and which direction is the reform? It's a broadening and developing concept of health and responsibility for health. This health should be reformed, the concept of the health should be reformed, the concept of health and responsibility should be reformed and reorganized in our health system. And we also need a developing a business checkpoint management of NCD, because in our budget, we are very limited with the non-contributory project. Already Dr. Redon mentioned an OWC in the budget. So we need to make a case presentation for business investment of NCD. And we need to define how to finance the NCD program, because NCD program is not an activity, it's a project. We need many much more resources, both for student customers, also for money to control the non-contributory.
Very much for welcoming all of us here and for your hospitality. I had a lovely day of the food short thus far. Today I'd like to speak about the maternal health record. So we'll review the history. We'll do a tour of our electronic medical records called EPIC, which I heard referred to already today. And then a few closing thoughts. So in historic times, the medical record consisted primarily of a problem diagnosis and a treatment only. And about 1960, Dr. Larry Reed started something called the problem-oriented medical record. This was used to independently re-verify information so that a third-party observer could take that information and reestablish a diagnosis and treatment plan. And in the 1970s in the U.S., the Department of Veterans Affairs started something called VISTA. This is the Veterans Health Information Systems and Technology Architect. This was the first government investment in the electronic medical record. In 1972, the first independent medical record was started. This was the Rugenstrick Institute. Moving into the 80s and 90s, VISTA A was released from the government to the public. In 1982, rapid dictation was started. A lot of the older generation physicians that I had the opportunity to work with still recall dictating all of their notes and all their records and having that be their primary modality. I think that's continued in our emergency department that uses primarily dictation as well. In 1991, the Institute of Medicine recommended that by 2000, all physicians should be using computers. In the 1990s, we had the establishment of several medical record systems called NextGen, Eclipsys, which has since become Allscripts. eClinicalWorks was founded at that time as well. In 1996, HIPAA was started. This was designed to make healthcare more portable and also to protect health information for patient confidentiality and disclosure reasons. There was also the VHA which mandated health electronic record use. Moving into the 2000s, Centricity was established, which we used previously at Maine Medical Center. President Bush promoted the electronic health medical record adoption in 2004, further establishing the need for an electronic health record. And then in 2008, the establishment and evolution of personal health records started. In 2009, President Obama started the HITECH Act, which provided financial incentives for individuals to switch to an electronic medical record. In 2011, we have the Accountable Care Act, which is establishing a need for physicians to practice medicine that they're held personally accountable for outcomes with. So taking a tour of Epic, which is our personal health record, located, patient names, I can real time tell which physician is accountable for which patient and who I need to contact. Over here, I can tell cervical dilation, I can tell the G's and P's of my patients, their gestational age, I can tell how long they've been here, their group B stress status, whether or not they're on Pitocin or being augmented, or if they have any need for fentanyl or analgesia during a procedure, and I can tell why each of these individuals are here. This facilitates my ability to care for patients in a very timely and concise manner, as well as keeping an era where patients are taking onus of their own health care, and I think that that's something important when we're considering all of the other attributes with obesity, diabetes, diet, healthcare, diet and lifestyle modifications. As indicated here, we have remote access, so it's very easy to get to. And it also facilitates dynamic patient handoff. So when my colleagues and I are looking through and we have any questions, it's very easy to get into a patient's chart, readily figure out information and make sure that we're providing the appropriate treatment to the appropriate patient for the appropriate reason. So where do we go from here? I think that in the probably distant future, we'll have a nationally and globally accessible information. It'd be great if I was traveling here and I had a health problem. You could log right on, see my full health record, and pull that up easily. I know that the U.S. government is really the biggest national electronic medical record with the Veterans Affairs that's currently accessible. Patients will be able to control this in the future, be able to have their own health information and access that. Potentially, we could place it in the cloud, so it's something that would be available online, or have something like a wearable chip. If someone came in unconscious or without full documentation, or someone had altered mental status or inability to really provide this, it would be nice to be able to see on the stand like a barcode and know all the information. And then I think in the U.S. especially, we're seeing that performance-based compensation that's currently evolving. So we're evaluating patient outcomes, and physicians are being held accountable for our patient outcomes, where they're looking at compensating physicians only if they're meeting certain measures and certain goals. So I think that that's something that we're going to have to continue to take into consideration as our treatment for patients evolves as well. Thank you very much for having me today.
It's my gratitude to the organizer for this presentation. The evidence from both all the three speakers mentioned about the importance of medical information. For the implementation of the medical information service
to help us to correct the medical problems and to plan and to implement how to solve the problem. For which we require a very good infrastructure which covers the whole population of the country. Number two, we require sufficient manpower to cover this problem. And number three, which is the most important, is the motivation of the workers. Here, and number four is probably financial support from different sources or especially the government motivation. And not the least important is the administration. In our system, what I mentioned about the infrastructure, Bangladesh is providing very, very good medical healthcare delivery infrastructure which covers almost all the communities, even in the rural. We are union having one community clinic. So it is sufficient to cover the whole population. But unfortunately, for the manpower, there are not only the doctors, we have got paramedics, other health service delivery system is there, health division, and even the clinicians, lots of people are working in union level, in hospital level, but unfortunately, they are not motivated. Here is the lack of problem. And if there is a motivation, this motivation is wrongly implemented.
Likely, Professor Ridwan Rahman has mentioned, even the writing of the death certificate is only, if you go through the death certificate, almost all the death is due to cardiovascular failure. How come? They have not mentioned the diagnosis initially, what is the cause? Because of this. Wrong in the printing of the death certificate. There, but in my patient, 2 columns there. What is the diagnosis? What is the immediate cause of death? So, all the people, all the doctors who are working, all the parameters, they are not motivated regarding what is the difference between the diagnosis, what is the cause between the. They need, before writing it, they should be oriented about that system. That's why there is a wrong data collection, all the days is due to cardiovascular failure. If there is a causes diabetes, maybe that is a decision. He is not trained how to write what is to given the immediate. That is the problem in that system. That is the wrong information, we are getting wrong information that all the days is due to cardiovascular failure. That's not true. Here is it. So the system, the collection system should be, all the doctors and the paramedics should be trained prior to joining there, and its importance should be very highlighted in their education process. What is the importance of the medical information service? And recently, the government is around the digital
question, which is very important to address. আমরা দেখেছি ওয়েস্টার্ন বাংলায় বলছি যে সবার জন্য সুবিধা হবে যে আমরা দেখেছি যে রুরাল এরিয়া যেখানে ডক্টরের উপস্থিতি কম থাকার কারণে রোগীদের রেজিস্ট্রেশনটা সঠিকভাবে হচ্ছে না। তো আমরা যত ডক্টরই আমরা রিক্রুট করি না কেন, এর সুফল আমরা পাবো না যতদিন পর্যন্ত ডক্টর তারা সার্ভিস রেজিস্ট্রেশন না থাকে। সো এইটাকে আমরা কিভাবে এনশিওর করতে পারবো, বা ডক্টররা তাদের সার্ভিস স্টেশনে নাই, এটাকে কিভাবে আমরা ন্যাশনালি আমাদের সেলের মাধ্যমে বা আমাদের ইনফরমেশন টেকনোলজির মাধ্যমে আমরা কিভাবে এটাকে মনিটর করতে পারি সেই বিষয়টা অ্যাড্রেস করার জন্য বা সেই বিষয়টা আমরা কোনো স্টেপ নিয়েছেন কিনা। 2 নম্বরটা হলো যে আমরা অ্যাডভোকেসিতে দেখেছি যে প্রায় 4,500 ডক্টর রিক্রুটমেন্ট হয়েছে এবং আবার প্রসেসিং এ রয়েছে এবং তাদেরকে ম্যাক্সিমাম জায়গায় কিন্তু পোস্টিং দেওয়া হচ্ছে রুরাল এরিয়াতে। বাট আনফর্চুনেট আমাদের জন্য যে তারা কোনো না কোনোভাবেই রুরাল থেকে আরবানে চলে আসছে টু ম্যানেজ সাম পিপল। তো সেই বিষয়টাকে যতদিন পর্যন্ত আমরা নির্ধারিত করতে না পারবো, তাহলে আমাদের যে কমিউনিটি হেলথের যে আমাদের যে গ্লোবাল কনফারেন্স, যেটা ফিলোসফি এবং স্ট্রিট, যেটা যে সবার জন্য স্বাস্থ্য নিশ্চিত করা এবং ডোর টু ডোর যে এলডারলি পপুলেশন বা কার্ডিয়াক প্রবলেম যারা আছে এদেরকে এনলিস্টেড করা এবং এদেরকে সার্ভিস প্রোভাইড করা ততদিন পর্যন্ত সম্ভব হবে বলে আমি মনে করি। থ্যাংক ইউ সো মাচ।
How it could be affected in Bangladesh, as our government is saying, specific powers in digital Bangladesh. So they have their services detail on how our country can help electronic health record. Thank you very much.
Prevention, and you mentioned the prevention. Dr. Malik is here. He is an expertise for the preventive measures. In our country, curative measures are taken very much, but prevention measures are negligible state. Do you have any plan to work on prevention? Thank you.
প্রফিটুদ্দিন স্যার বলেন যে হাসপাতালে চিকিৎসা আছে কিন্তু সেটা মাত্র পেপারে, কিন্তু বাস্তবতা কার্যক্রম না, বা হাসপাতালে তাদেরকে তেমন একটা পাওয়া যায় না। এটা দেখা যায় যে গ্রাম অঞ্চলের বিশেষ করে প্রত্যন্ত অঞ্চলগুলোতে যতগুলো হাসপাতাল রয়েছে সেখানে চিকিৎসা ব্যবস্থা মানবিক নিম্ন। এর মধ্যে ডাক্তারদের যে কর্মকাণ্ড সেটা অন্যতম। পাশাপাশি চিকিৎসার যে সরঞ্জামগুলো সেই সরঞ্জামগুলো অনেক অনুন্নত হয়, এবং পাশাপাশি নার্স এবং যারা থাকেন বা চিকিৎসা কেন্দ্র হাসপাতালের যে পরিবেশটা, সেই পরিবেশটা অনেক ভিন্ন হয়, যার কারণে দেখা যাচ্ছে যে চিকিৎসা নিয়ে গিয়ে এবং তারা মৃত্যু শিকারী হচ্ছে বেশি। আর এক্ষেত্রে দেখা যাচ্ছে যে গর্ভবতী মহিলাদের বেশি শিকার হচ্ছে। পাশাপাশি দেখা যাচ্ছে যে বাংলাদেশে গ্রামাঞ্চলগুলোতে এমনকি মফস্বল শহরগুলোতে অনেক ক্লিনিক রয়েছে, যে ক্লিনিকগুলো প্রতিবারই কর্মসূচিতে এই ঘরে তুলে সেই ব্যক্তিরা। আমার প্রশ্নটা হচ্ছে যে
সরকারের পাশাপাশি এই ইন্টারন্যাশনাল অর্গানাইজেশনগুলো কি কোনো পদক্ষেপ নিচ্ছে বা সরকার কি সহযোগিতা করছে এই বিষয়গুলোকে দূর করার জন্য, অর্থাৎ হাসপাতালের চিকিৎসা ব্যবস্থার মান উন্নত করা এবং ওই ক্লিনিকগুলো বন্ধ করা?
ঠিক আছে, অনেক ধন্যবাদ, অনেক ধন্যবাদ। আপনার কাইন্ডলি প্রশ্নটার নামটা বলবেন, তাহলে
আমি এমপি স্টুডেন্ট। থ্যাংক ইউ স্যার, আপনার দিকে আপনি বলেছেন যে আমাদের যে ডিজিটাল পেপারগুলো ডেথ সার্টিফিকেটগুলো অনেক সময় ডায়াগনোসিস এবং প্রেজেন্ট কমপ্লেন্টে রাখা হয় না, সেটা আমাদের দেশে কিন্তু আমি একটা রিসার্চ করছি, আমি কনসালটেন্ট আমার টপিক হচ্ছে এবার এটা বের করার জন্য আমি কিন্তু হেলথ ইনফরমেশন সিস্টেমে নিয়ে কাজ করছি, যে কোনগুলোতে আমার মেইন কাজ আমার কাটাটা বেশি। আমি পাবলিক প্রাইভেট অটোনোমাস three types of hospital I will go through for data collection, but I cannot recognize that the information about disease or diagnosis. The doctor was in there, but paper cannot stop. I really thank you for the message you are talking in global conference and communication. And my question is that about for teaching how we are improve our health system globally, or your ethics was applicable in our hospital. How we are used in our system. That's my question.
Thank you. So it's now over to you. So
I would like to thank the organizer of the Global Conference on Community Health. I also thank the speaker for a very nice presentation. As you know, that non-communicable disease is an established fact that it is emerging a serious health problem in not only Bangladesh, all over the world, and particularly developing countries. Because of many factors already the speaker has spoken, diet, lack of exercise, use of tobacco, and stress and strain, many factors. But if you want to control this disease, one speaker has told about prevention, because it is very important. All these diseases, cardiovascular disease, cancer, diabetes, and also chronic lung disease, does not occur suddenly. It is taking time to develop, and it goes on years together to develop, and manifestation takes place suddenly. So we should try to prevent this disease, very important. And prevention if you want to do, then communication system is very important. And in our country, unfortunately, two handicaps there. One is ignorance. Most of our people are ignorant about the disease. And the second is poverty. So we will have to overcome all these diseases. And if you want to give a definite effective manifestation of prevention of diseases, then government alone cannot do. Policymakers, government, all the non-government organizations will have to come. Teachers, religious teachers, press and media, they will have to come. And we will have to tell again and again this message to people that prevention is very important, is effective, and we should do. So prevention, screening, we should do. As you know, Heart Foundation and other organizations, they are also working. The Eminence, they are also working. So many non-government organizations are coming up. We have to strengthen our activity, coordinate our activity, and government will be definitely a coordinator. But all of us should work together and tell the message, not do small, do physical activity, control diabetes, control hypertension, less talk. This message we have to tell again and again. And unfortunately, this is coming up. Means if you see the strength of disease, we are strong in our country, it is going very high. And once you do not give a effective measure,
it will be very dangerous to control the disease. I sometimes go to our tissue, and when I see people below 40 are getting this type of ischemic heart disease because the change of diet, fast food, lack of exercise, use of tobacco, these are very important factors, and they are getting ischemic heart disease. And this is an economic burden to family, society, and the nation. Infectious disease is that he is cured or he is killed. But this type of chronic disease is dangerous because one is a rocker, it is a chronic. And chronic disability, economic burden, cost of medicine, cost of treatment are very costly. So we will have to go for effective prevention of disease. And all of us should work together, not only government, all the political leaders, every citizen, civil society, teachers, everybody should come to us. We should work together and our communication system should be improved. So media should play a very important role. I again thank the eminent and other organizers for inviting me. All of us should together. We cannot achieve success in a day. It will take time. And we want to see the results in the field, the supply. But we have to start from now and effectively. This is not a suffer work. Action is very important. You already there, action is very important. That's what we are people in that show. We have got good infrastructure in our country. But we must be effective, and if you want to do effective results, all of us should work together. People should do action is very important. Thank you very much for inviting me. Thank you.
Good afternoon. My name is Elizabeth McClellan, and I am the founder of Partners for World Health. And I want to thank you very much for offering me the opportunity to speak to you about a topic for which I have great passion. We are, whether you're in a hospital or a clinic or in the operating room or in the emergency room or even in a patient care area, supplies are essential for taking care of patients. Without them, the healthcare team cannot do their work, and ultimately, the patient is the one who suffers. There is a tremendous need for medical supplies all over the world and in so many countries where we have been. The picture you see here is the delivery room table in Tanzania. And as you look at it, there is absolutely no equipment for the care of the mother or the baby. In the event of an emergency, they have no touching machine, no oxygen, nothing to be able to resuscitate the mother or resuscitate the child. And anyone delivering a baby under these conditions will suffer. This is not right. This is not the way it's supposed to be. This is not fair to people in the world. And if we want to improve the quality of care to people in our world, we must provide them with the tools that they need. The fact about our medical supply delivery system is that there are many different ways for developing countries to ensure supply. Government agencies, NGOs, people in the private sector, religious organizations offer different methods of obtaining medical supplies that you all need in countries worldwide. However, we run into difficulties because local governments sometimes and customs officials can either make it relatively easy or extremely difficult when we bring those medical supplies into the country.